This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. This morning we have our own Dr. Dan Sorescu as our speaker. Dan did his medical training in Romania, did his residency at Beth Israel Albert Einstein in New York, and came here as a cardiology fellow. And I remember when he interviewed, he was perhaps the most enthusiastic interviewee we had ever had for the fellowship program. And Dan has progressed through the ranks, is now an associate professor. One thing I always think about Dan is probably one of the smartest people I know, is able to pull together a lot of data from very interesting areas and present some interesting stories. And today it appears no different. We're going to learn about industrial overfeeding, and we'll understand what that is.
Good morning. Thank you, Bob. So first of all, I would like to disclose that I have no conflict of interest. Okay. So topic of this lecture, it's about obesity, and we know obesity, it's not only a United States epidemic, but also a global epidemic. However, the question is it really the obesity that matters when it comes to cardiovascular disease, or is just pointing to something else that causes obesity and cardiovascular disease? So going along that line, I hope I'm going to try to convince you that over the next 45 minutes or so that it's not obesity per se, but actually how you acquire obesity that makes the difference, and particularly the type of nutrition, industrial nutrition we are dealing with nowadays. So it's always nice to start with a complicated patient. I'm not going to bore you and go over in details over this, but I just wanted to set the big picture, and we see this more and more frequent in our practice. I would say in our heart failure clinic practice, probably it's 1 out of 2 patients present like this nowadays, at least the ones who are admitted in the hospital. And out of 20 patients on the service every day. So 64 years old woman with history of morbid obesity, over 300 pounds, sleep apnea, high blood pressure, diabetes, comes with acutely decompensated heart failure, atrial fibrillation with rapid ventricular rate, and anasarca. And clear, she's had 2 recurrent admissions for heart failure, volume overload, and she's got acute renal failure and severe pulmonary hypertension, so-called heart failure with preserved systolic function. So this is a typical example of a patient who is obese, has got major comorbid illnesses. And the question is, how does she get it here? Obviously, this takes over 30 years. If I were to try to make a progression of a disease, and again, by all means, this is a very simplified version, I would see that about maybe 30 years ago, this patient maybe would have presented to an outpatient primary care clinic as a patient who's just morbidly obese with borderline hypertension and maybe a little bit of prediabetes or metabolic syndrome, maybe sleep apnea, maybe not. About 10, 20 years later, one could see a patient like this can evolve to have full-blown diabetes type 2, stage 2 hypertension, which becomes now resistant to treatment, and may present every once in a while in a hospital with heart failure with preserved ejection fraction. And then last but not least, will evolve eventually 34 years later to the patient I just presented to you. And then when it comes to us, it all looks like, well, we got a lot of different illnesses here that we got to treat, but it's possible that all these illnesses may have actual common denominator to begin with, and maybe that's why it makes it so difficult to treat. So few examples. Once each of the illness is acquired, brings on other problems. And of course, there is disease interaction here. For example, obstructive sleep apnea per se has profound impact on any cardiovascular disease. If you look in general population, about anywhere between 45, really up to today is considered up to over 50% of patients with heart failure will have some version of sleep apnea, whether it's central obstructive. It's also up to about 50% of our patients with acute coronary syndromes. And if you do have that, then immediately your risk of dying from coronary disease, it's way higher, about 5-fold higher than if you don't have obstructive sleep apnea. And then resistant hypertension, now it's about 2/3 of all our patients with resistant hypertension. When it comes to heart failure, actually obstructive sleep apnea has become, or central sleep apnea actually has become, together have become probably one of the single most important risk factors for negative prognostic and negative outcomes in heart failure, way worse than ejection fraction, and up there with renal failure in terms of the odds ratio to die from it. But what is it really, obesity or heart failure related to obesity or sleep apnea. And it's very difficult to point the fingers out. There is no matter how hard we try to find a certain phenotype, clinical phenotype, you can find just old-fashioned heart failure, cardiomyopathy, left ventricular hypertrophy, left ventricular dilation version sometimes. You can have biventricular hypertrophy, and it's really very difficult to point out the exact phenotype. And often it's co-associated with refractory hypertension, with pulmonary hypertension, coronary disease, strokes, acute coronary syndrome, dyslipidemia, last but not least, central obesity and insulin resistance with diabetes type 2. And if you do have sleep apnea, then you're more likely you're going to develop atrial fibrillation, usually really at the end of the disease. You're more likely to develop heart blocks and sudden cardiac death, and pretty much aggravates every other cardiovascular condition that we know. So this is a obesity, if you want end-stage obesity or morbid obesity. It's not a single entity that you can just point out. And even when you just think about a single cardiovascular entity, it's very pleiotropic. What we do know, though, is that at least obesity related to sleep apnea, obstructive sleep apnea that's associated with obesity, it's a potent activator of the adrenergic system. If you look at these polysomnograms, when you look at the blood pressure during and sympathetic system, nervous system activation during sleep, notice that as soon as the patient has hypoxia or the apnea episode, there's a tremendous activation up to tenfold of the sympathetic system. Basically, it's like the patient is running a marathon where he's trying to sleep. The same with the blood pressure and the same with other activities on the electromyogram. So obstructive sleep apnea is associated with tremendous sympathetic activation, particularly at night, and then the opposite, hypersympathetic system activation too. It is associated with inflammation, so and cytokine activation. It is, and when you look back and say what causes obstructive sleep apnea, the single most important clinical predictor to actually predict who's going to develop sleep apnea is your sudden weight gain over 7 kilograms, 15 pounds in a year. So if you gain and you keep it there in a year, then you're more likely you're going to develop that. So by itself, it appears that everything is about obesity here. Nonetheless, these patients also, this is just an example of inflammatory markers and oxidative stress activation, not only in the adipose tissue, but also in the plasma and in the vessels. So going back to obesity and heart failure in African Americans, a cardiac study has noticed that blacks have a 20-fold higher risk than white to develop heart failure in the U.S. population, particularly if they are less than 50 years old. The main predictors in these particular patients, when they were published, is that hypertension, obesity, BMI over 32, metabolic syndrome, systolic dysfunction, and now, although this has not been studied, I bet you a lot of these patients possibly have sleep apnea. So again, I would say this looks very similar to the phenotype that I was presenting earlier in stage 1 and stage 2 heart failure related to obesity. And more recently, indeed, an elevated BMI has been documented a year ago into a study in a New England journal that indeed the higher BMI, the higher the risk of cardiovascular disease, whether you smoke or you haven't smoked. So basically, high BMI per se, it's associated with cardiovascular disease. The fact that obesity has been a risk factor for heart failure has been known already for a while and was published in 2002 in New England Journal. And at that time was a big issue, controversial issue, because if you say that obesity is a risk factor for heart failure, and heart failure is caused by hypertension and coronary disease, then obesity is not a risk factor of coronary disease. How come it's a risk factor of heart failure, which is ischemic cardiomyopathy? At that time, there are only two-thirds of the all heart failure. So I'm going to try to convince you that there's more to it, because obesity is becoming now, and particularly morbid obesity, is becoming a major epidemiologic trait, epidemic in the United States and in the world. And probably most of you are familiar with this picture. These are in 90s, the morbid obesity in this country were under 10% across the country. If you look in 2000, they have increased in the 20% range, and now in 2010, increased over 30% range. And you can see the hot spot radii, the red areas are in south, particularly southeast. And then this begs the questions. In 20 years, we have become more fat than in a million years. There's no way we had the time to really get our genes involved into this. Part of it could be clear, some genetic susceptibility to acquire more weight or do something about this, but this we cannot, it's only so much we can blame 20 years worth of change in morbid obesity on genes per se. As a matter of fact, everybody thinks that if we were to import Michelangelo's David, we'll return in Italy in 2 years way morbid obese. And the question is, are we going to evolve towards Homo obesicus? And that's associated with the fact that we're really spending a lot more time in front of computers and in sedentary activities. So it's not actually just obesity, it's also obesity associated with insulin resistance. So if you were to pay attention is, okay, we have gained weight in this country in the last 20 years, but what else have we done in the same time? Turns out there's a perfect overlap between new onset diabetes type 2 and morbid obesity. So in other words, we have acquired, those of us who have gotten and are become morbid obese, we also acquire insulin resistance with that. So this is the morbid obesity associated with cardiovascular illness, because we know insulin resistance is what really makes the difference between healthy obesity and bad obesity. And again, it's in the same place. And that occurs also with heart failure. If you were to go back and look at the strong heart study, if you look at heart failure per se and insulin, this is the cumulative incident risk of heart failure, and this is the plotted per whether you have normal glucose, impaired glucose tolerance, or insulin resistance. So notice that the more insulin resistant, more diabetic you are, the more likely you're going to develop heart failure. So if you go back and we try to figure this paradigm, what is it really that's associated with this heart failure related to obesity? I think it's probably not the fact that 20 years this obesity and insulin resistance have increased so fast is probably related to how the obesity has been acquired. And genes have a role probably in making you more or less sensitive for what you're eating, to what you're eating. But I think at the end, I'm going to propose to you that it's a chronic overconsumption of sugar, fat, and proteins processed through or coming through the industrial sources that makes the difference. If you look into that I think causes the central obesity or the bad kind of obesity, insulin resistance. It causes dyslipidemia and cardiovascular disease. Again, this is a hypothesis that I'm going to propose to you. Causes liver steatosis, cancer, dementia. It's been for a long time. Declining life expectancy and quality. And as Angelina Jolie has said, quod me nutrit, me destruit. What feeds me also, or nourishes me also, destroys me. So let's see if I can convince you about this. And the way I hope I can convince you is I took some of these dietary changes or the specific of this industrial feeding, and we give it to an animal model that's designed by Mother Nature to, although it can be omnivore, it can eat anything, actually most of the time it's a vegetarian. It's been exposed for a million years to veg, and those are the mice. So I'm going to put them on an equivalent of a burger a day and a high fructose corn syrup from a soda a day, and then see what happens. Now I wanted to point out, so I just mentioned that really I don't think here we're talking about only obesity. We're not talking about heart failure and cardiovascular disease. We're talking about potential nutrition element causing or contributing major to all of these other illnesses that are outside of cardiovascular system. And so, as I mentioned earlier, first of all, there is a recent review study in Science about 2 years ago. They look into, from all the genes we know that could explain the high BMI, how much is explained by genes that we know, at least at this point. And really they found that less than 1% of the high BMI obesity and 5 to 10% of all diabetes are explained genetically, at least at this point. Of course, the same like in heart failure. I'm sure that with time this is going to grow, but that was at least as of 2 years ago. And what I'm going to try to propose to you is that probably is the nutrition, particularly from fast food industry, that makes a major difference here. So, and there are certain elements in that can make a difference, and exactly the importance of those elements is highly controversial and debated. You can realize that there's a lot of debate here, but elements that can make a difference are high fructose corn syrup, lack of saturated fatty acids, lack of the protective omega-3 fatty acids through the industrial processing. For example, it's well known that chickens or animals that are fed in an industrial setting have almost no omega-3 fatty acids in their eggs or in the body compared to the ones that are free roaming or grass-fed. Simple example, presumably about 100,000 years ago, the omega-3 to 6 ratios in our diet was supposed to be 6 to 1, and currently we have probably the bad to good guys about 20 to 1. So the same way with the sodium and potassium, which has been reversed. So there are clearly some things that we have changed very fast in our diet. So in order to test the hypothesis whether feeding a diet is very similar or try to reproduce a fast food kind of diet, or Western type diet, what we call, we look into, together with Dr. Frank Anania, it's his suggestion actually, who is the head of our hepatology here, we look into a diet that's been studied by a group from University of Washington, St. Louis. It's called the ALIOS diet, the adult lifestyle induced obesity syndrome. This diet is based upon the nutritional makeup of a Western type diet, although the effects of high fat diet and high cholesterol diet on the cardiovascular system has been studied before. There used to be extremes. So for example, 60% high fat diet versus 60% high fructose corn syrup. I think that doesn't necessarily reflect what we do every day. So this is a diet that has a little bit of everything. There's no extreme into it. It's very similar to what we go out and do every day. About 45% of the calories are derived from fat. 30% of the fat is derived from trans fat. And diet also included high fructose corn syrup, which you need to understand that the high fructose corn syrup doesn't just have high fructose. It has actually high fructose and has sucrose, and the difference is about 55% fructose versus 45% sucrose. So it has a little bit like what we have, just a little more fructose than the regular sugar will have. And that's about 2% in their water to mimic the soft drink consumption rates in Western diets. And this here I'm just going to summarize what those authors have published in their paper. The Tetri is really the first author on that paper. It was published in 2008. They have very clear characterized that this kind of diet, if you put it on mice, give it to mice who are 5 weeks old, so that will be a human who is 6 months old. They just got weaned off from breastfeeding. If you put them on this kind of diet for about 16 weeks, then you will cause dyslipidemia, high blood pressure, elevated uric acid level, increased appetite. Normally when we eat, ghrelin is secreted by the stomach. It's supposed to, ghrelin is the hunger hormone that's normally suppressed once you eat. Unfortunately, fructose does not do that. So you can binge a high amount of fructose and your brain doesn't know that. And the same insulin resistance. There are very few receptors, or almost non-existent, in the heart, in the pancreas, and in the brain for fructose. So only the liver will know that you just had a big binge of fructose if you do that, if you take a soda. So, and it will not, the liver then will interpret that, well, it's too much abundance, and will start to convert that fructose straight to fat. It's actually the most fatogenic substance that we have right now. It's more than the alcohol per se. And in the same time, the pancreas will not know to release the insulin. The brain will not know to turn off the appetite signal, and you'll continue to eat. So those are all potential side effects of fructose. Of course, the exact impact on humans is not clear now. But at least in mice, we took this diet, and then we wanted to test the hypothesis that this causes cardiac dysfunction. And mice were either on control diet, which is regular chow diet, or ALIOS diet. We performed echocardiography, blood pressure measurement, histology. We look at the RNA protein at 4, 8, 12, and 16 weeks after exposure. And I'm going to summarize here what we found is similar like with the other group, is that these mice do get obese. They get insulin resistance and glucose intolerance. I'm going to show you some data for that. They get fatty liver infiltration. It's probably right now the most accepting model by the hepatologists actually for NASH, non-alcoholic steatohepatitis, dyslipidemia, cardiac hypertrophy, and mild dilated cardiomyopathy. These are the last are our unpublished findings. So I'm going to show you, this is from the same paper with Tetri. This is a normal liver at 8 weeks after The top part shows you this is a smaller scale, this is magnified, and then look what happens with the mice after they're exposed for 8 weeks on this diet. All this, what you see white little bubbles, are actually the fatty infiltration. It goes all the way up to 40 to 60% of liver being replaced by those. And the relationship between actually dyslipidemia or coronary disease and steatosis has been actually seen by hepatologists a while ago. So if you were to look at all patients with coronary disease, or actually all patients with coronary disease here, these three groups, this one without coronary disease, if you don't have coronary disease, you have 50% chance to either be on having hepatosteatosis or not. But once you start to have single 2-vessel or 3-vessel coronary disease, your risk of developing liver steatosis is up to 100%. So pretty much advanced coronary disease, advanced liver disease, it's 100% overlap, okay, which is very fascinating. And I will show you why. This particular animal model appears to reproduce exactly the same thing. If you look from, so when we look very careful at these hearts, after the mice have been exposed to this diet, they actually develop a dilated cardiomyopathy phenotype. Initially, they get cardiac hypertrophy, and then eventually they get dilated cardiomyopathy. And their hypertrophy starts as early as 4 weeks and keeps going up. Here is evidenced by the heart weight to tibial length ratio. And then when we look at the fractional shortening, which is the surrogate for ejection fraction, and end systolic diameter, notice that nothing happens. There is no left ventricular systolic dysfunction for about 8 weeks, but starting with 12 weeks, you start to have statistically significant drop in your fractional shortening, and which keeps getting worse by 16 weeks. They will get, I would say, more of a mild phenotype, so it would be an equivalent in human of an ejection fraction of 35%. But nonetheless, remember, the only thing I manipulate here is the diet and nothing else. And then they also get their end systolic diameter starts to go up, and the end diastolic stays the same. I didn't show it here. So suggesting more of a dilated cardiomyopathy phenotype. And so the question is, what's the evidence of in humans that you have a similar phenotype? And you cannot do this prospective experiment for humans because it would be unethical. So you can't take somebody and put them on fast food diet and then reassess them 100 pounds later. But you can do, we have though the reverse natural experiment. So there are patients who have lost over 100 pounds from 400 to 300 or from 300 to 200. And they're very well studied from cardiovascular standpoint, diabetes standpoint, every condition. And we know it's associated with morbid obesity. And notice here that whether you lose your diet with, whether you lose this amount of weight with diet or you lose it with surgery, it doesn't matter. You still have the same. You reverse your cardiac hypertrophy. You reverse your left ventricular mass, ejection fraction, right ventricular mass. Okay. While if you don't lose any weight, nothing happens, or if there is anything, it's going to get worse. And these changes were not present not only in the heart, but also, in other words, in this particular obese patients, before they got the surgery, they had big, thick hearts and also stiff arteries. They have arterial compliance issue, and all those both arterial and ventricular changes actually are reversed after they lose the 100 pounds. And this is not present just with, these are not just cardiovascular endpoints. We know their diabetes reverses, their blood pressure can go back to normal. Those are all documented in other kind of literature. So if we want to, we have these hearts, they get cardiomyopathy in mice. The question is, what is the mechanism? How is this happening? And is there any way we can try to interfere with this? You see, it's very easy to say to somebody, don't go and eat fast food. 100% that's not going to happen. So we need to find a way, what are the mechanisms? Can we really sort out the bad obesity from the good obesity? Maybe we can still allow, you have to accept that humans will go and eat whatever they want to eat. And the question is, can we protect at least their body by identifying the proper mechanisms how to do that? So when we try to look at this and analyze at 4, 8, 12, or 16 weeks from the RNA standpoint, what's happening with their genes, we notice that the genes that are the first gene that is turned on as early as 4 weeks actually is turned off if there is anything. It's called PGC1 alpha. This is a sensor. It's a sensor for energy metabolism in the heart, actually in the body, in the liver, and the skeletal muscle. This particular, it's a transcriptional activator that controls the mitochondrial biogenesis. So each time a certain organ feels like I need to produce more energy, immediately this guy is turned on and it will start to do his job. If it's turned off, it's bad news. It will impair mitochondrial biogenesis. in the same time, elements that are downstream of insulin, particularly insulin resistance, like FOXO3A and natrogene, these are upregulated when we have a fasting and starving response, actually. It actually correlates with insulin resistance. The next is our very well-known angiotensin-converting enzymes, goes up about tenfold as early as 4 weeks, stays up to 16 weeks, at least as far as we look at. Then the uncoupling protein 2, it makes free radicals when the mitochondria are unable to make ATP, so it's a sign of mitochondrial dysfunction. And then our well-known atrial natriureactive peptide and TGF-beta, those are activated. It really signals a shift to a fetal phenotype. So what that means at the end, and there's lots more data, I just didn't want to overwhelm you with that, but bottom line, at the end, this is what we notice in these hearts. There is a mitochondrial dysfunction and lack of mitochondrial biogenesis. There's oxidative stress. The mitochondria that are left over, they don't make ATP, they make free radicals. There's insulin resistance, there's cardiac hypertrophy. And what's interesting is you say, well, you have more heart muscle, so things should be good. But it's more of a heart muscle that has switched to fetal phenotype. Well, what does that mean? It's when we're in fetal life, we have low oxygen and we have low sugar and we have glucose. The heart does not utilize fatty acids. So that's wonderful because the heart switches to that phenotype to adapt for lower substrate available and lower oxygen available. The bad news about that is that the ejection fraction of those fetal, it's only 25%. They don't need to lift up 110 millimeters mercury of blood pressure. That's a very low pressure system. And then the price you pay for adapting for low metabolism, you actually reduce your ejection fraction. I think that's at least my take-home message from this. So it's very interesting. You put them on a diet and you make them back switch to fetal phenotype. And that's, they also get, this is our data. They show impaired glucose tolerance. So this is not just a heart issue. It's a general issue, metabolic issue. Then when we look in the heart, you say, well, how do you know that the heart is starving or it's insulin resistance? So I wish we could do this in real life because I think in diabetes, what we're missing the boat is we define diabetes as an impaired glucose, and we only look at glucose. But you have to understand that's a homeostatic variable. Glucose is the last to change. What really changes first always is the insulin, and particularly insulin resistance, how tissues are perceiving. And what you see here, the baseline, the way to measure insulin resistance is to look at the AKT phosphorylation in the heart, and that is a protein that's very sensitive to glucose environment in the plasma, and that protein is downregulated after 8 weeks of exposure to this diet. And what's interesting, we also took the mice, we put them on this diet for 8 weeks, and then we stimulated them with insulin, and we want to see how is if we give insulin from the pocket, what's happening with the same AKT phosphorylation. And notice that these particular hearts, we harvest them 10 minutes later, these particular hearts are not able to respond to insulin as well as the other ones who see regular diet. So these hearts clearly are insulin resistant. Remember I was telling you some elements. Insulin's job is to suppress the fasting state and tell the heart, go ahead, time to uptake glucose. And the way it does that, it's actually suppressing this guy called FOXO3A. And what happens is if insulin does not do the job, then the FOXO3A goes up in the fasting state to protect the heart, and it's telling it switch the metabolic engine to a fasting state. Well, it turns out that these particular mice, once you put them on this diet, they have a lot of the FOXO activation. I showed you the RNA goes up, but also it moves in the nucleus, which means it's active, and also a protein that's only produced by FOXO goes up. It's called atrogene, which is actually a proteolysis protein. What it does, it cuts proteins down. Actually, it could be part, in my mind, of how the heart gradually shifts from in order to shift from an adult phenotype to a fetal phenotype, you have to first destroy your adult fetal proteins. It's possible atrogene and other enzymes like this are involved in this early response to do that. All right? And then also, this is a proof when you look in the hearts. Remember how you have that burn oil from that's used that after you make the burgers and it smells bad. Well, it turns out that's given by the oxidized fats and proteins. And I can do the same thing with the antibodies, look in their hearts. So these mice, when you look in their hearts, what you see here brown in the nucleus or in the membranes is the same. It's like you have burned that oil in the hearts. It's the same marker. You have oxidized fat and proteins. So if I were to summarize what so far we have, what we understand about what's going on in the hearts of these mice after being exposed to this diet at molecular level. First, turns out, I didn't show you this, that these hearts downregulate their glucose transporters, which means they are paradoxically in an environment you have plenty of glucose and fats. Actually, they downregulate their glucose, and actually you're not getting glucose inside the cell. The same way you're not getting fatty acids inside the cell, free fatty acids, and the enzymes, they metabolize those. Then we downregulate the mitochondrial respiratory chain. That's the one that passes on the energized electrons to produce ATP. The ATP synthase, the main enzyme that makes ATP, is downregulated. And then it turns out these mitochondria are dysfunctional because instead of using all those substrates to make actually ATP, they actually pass the energized electrons to the oxygen to make free radicals, superoxide molecule, through the uncoupling protein. So these are not good mitochondria, and at the end, it looks like this is a starving heart. And I found very paradoxically, there was a similar, 2 years ago, I put the title of my for grand runs as overnutrition leads to a starving heart. Turns out that Robert Lustig, who is now very famous or infamous for bringing the kids actually obesity epidemic in the main stream, he published this paper in 2006 saying the skinny on childhood obesity, or how our Western environment starves kids' brain. Turns out actually there's a lot going on. An obese brain is actually a starving brain. It's insulin-resistant brain, and that is the problem why you keep eating and want to eat more food, and you never have enough. All right, so that's very fascinating. So having said that, the brain is seeing the same thing what the heart is seeing. And then if you look from progression of heart failure, it turns out I can reproduce in 16 weeks at the molecular level everything that has been known to cause heart failure or end-stage heart failure. It doesn't matter what's the etiology. If you come from ischemic cardiomyopathy, if you come from non-ischemic cardiomyopathy, pretty much everything we have learned in terms of molecular, the genes that are turned on and off, and towards the starving metabolism, I can reproduce that by just putting the mice on this diet within 16 weeks. So going back to the question, is it the obesity, how you get to obesity that makes the difference? I hope I made the point here that if you were to say, well, I got heart failure, I got cardiomyopathy, it could be dilated, it could be hypertrophic, you get all the other stuff associated with it. Actually, I can just create that just by putting the mice onto this. Sure, these mice have early, maybe stage 1 cardiovascular disease. We haven't followed them for 6 months, 12 months, but I can tell you there are aging studies where they have put on similar type of diet, and if you were to continue this, they've been already published. Mice who, once they get to be full grown up, they will be equivalent of a human 56 years old. They all have heart failure and dyslipidemia and vascular disease. So then the question is, this begs the question, I showed you we're starting to identify and find some of these changes that happens in the heart. Well, is there anything we can do to try to reverse that within this setting? So the first one that I showed that little guy, the ACE enzyme was upregulated about 10-fold. So the question is, if I put the mice to begin with, the moment we put them on this diet, I put them on ACE inhibitor, an angiotensin converting enzyme inhibitor, can I reverse prevent the insulin resistance and end organ damage induced by Western type diet? And remember, that's why this came the idea for the fact, because this ACE enzyme is upregulated very, very early at 4 weeks and stays up it's probably the most dramatic changes at the molecular level that we encounter all the way up to 16 weeks. So yes, we did this study in mice. This is all unpublished data. We give them captopril, equivalent of a human. There will be 50 milligrams 3 times a day of captopril in their drinking water. And indeed, by 16 weeks, notice that this is the control. This is the ALIOS mouse. It becomes obese, and then in control with or without, and captopril with or without Western type diet, their weights all stay down. As a matter of fact, some of it even gets lower than this. Actually, we let them go first for 4 weeks, and then we put them on captopril. So we actually, pretty much whatever weight you had, they stop there, and some of them may even get down. All right, and then the effect of captopril is dramatic, not only on the weight, but also on the insulin glucose impaired glucose tolerance test. This is the captopril effect compared to the others. And then when we look at the hearts, notice that, I'm sorry, the abdominal first, the fat distribution. So captopril seems to be very good. I showed in reducing the fat and the obesity. The question is does it reduce the bad one or the good one? So then we can actually look at visceral fat. If we look at visceral fat, which is the abdominal fat weight, whether you look at 4 weeks or you look at 12 weeks, it completely prevents the visceral fat deposits in response to the ALIOS diet. So then when we look at the heart, with 12 weeks of ALIOS diet, you get, as I mentioned, a mild cardiomyopathy. You put them on captopril, that's reversed, and the same with cardiac hypertrophy, as when you look here at the heart-to-body weight ratio. So you get cardiac hypertrophy, which then reversed by captopril. So pretty much looks like every endpoint that we look at is prevented by captopril. The catch is the price you pay. The mice have a systolic pressure of 70, and I can tell you that each time we had to do any kind of anesthesia, even if it was to do isoflurane, a couple of them would die out of that experiment. So these are very frail mice. There's no way you can convince a human or their mother to put the patients or their kids on captopril the moment they are weaned off, or when they are 2 or 3 years old when they go out. So this will be complicated, but this just makes, and there's a lot of other things with captopril. It's not too clear how it works. ACE inhibition in these animal models have been studied. This is just our example in the mice and with this particular diet, but there are many other studies being documented. It's not too clear how it works, whether it really works on the brain, but on the mice, it's just is the low blood pressure, or they're just overall sick. So there's lots going on, but nonetheless, it's something that works, and at least it's a pathway that we got to think about it. If you think in clinical trials with heart failure, ACE inhibitors, when they're a patient with systolic dysfunction after heart attack, even without heart attack, the impact of those necessary number to treat in average is 40 to 1. All right? And HOPE trial also showed that even patients who have just high risk for cardiovascular disease, if you put them on a ramipril ACE inhibitor, then it prevents diabetes, 3 times heart failure. But really, the impact is actually very, very small as a necessary number to treat. So the question is, why is it that it's so difficult after the patients have already acquired the obesity? I think it's because we're doing it probably too late. I think if we were to, in other words, the study suggests that activation of the angiotensin system is required for the development of actual obesity and early stages of obesity illnesses. And I was trying to point out that the heart changes the phenotype, but so everything else. The liver is changing the phenotype. The adipose tissue is changing the phenotype. Actually, we're switching towards bad white kind of fat as opposed to brown fat, which can utilize very different. So once you switch the phenotype, I think you have to understand what is it that maintains that phenotype, and there are completely different mechanisms than the initiation part. And we need to study this and understand better, and then come up with better plans than what we're doing right now. So then the second study that we did, and I thought, you can't really convince humans not to go to eat fast food. You can convince industry not to bring on the fast food they have primed us to eat in the last 50 years. So maybe I can find something, a substance that if I can make the industry put it in the fast food, will protect the patient, and maybe they just get fat, they don't get the disease. So one thought would be, actually it's been there for over 40 years, is that we know there's a relative deficiency of omega-3 fatty acids, and I'm talking about fish oil derived, not the plant ones. And the question is, that begs the question, is dietary supplementation with fish oil derived omega-3 fatty acids, what we call the good fats, cardiovascular predictive in humans with diet-induced metabolic syndrome? So there is a lot behind it. It will take probably 3 hours to just go and review everything. I'm just going to give you the highlights. First of all, why? Fats are 2 kinds. There is a saturated fat. Everybody knows those are bad. And there is a polyunsaturated fat. Few know that polyunsaturated fat, they are not all good. All right? So there is the good part, which is the omega-3 derived, and there's polyunsaturated that at the normal amount is actually good. So the linoleic acid-derived arachidonic acid, it's absolutely essential for everything in the body. All our prostaglandins, leukotrienes, everything that we do every day in normal, physiologic state depends on this pathway. So these guys, they come from the plant omegas. These guys come from the fish oil omegas, predominant. And what's interesting is, as long as you don't have any chronic illnesses, you're fine. But if you have any chronic inflammatory condition, such as coronary disease, diabetes, dementia, anything, you name it. If you look at it, then all these actually taking too much linoleic acid can feed into arachidone pathway and actually produce more inflammation, can exacerbate. Rheumatoid arthritis has been shown that. Omega-3s that are derived seem to do exactly opposite for many reasons. First of all, the simple one is that they actually block those enzymes through competitive inhibition from creating more actually inflammatory biomarkers in those chronic inflammatory states, but also in the liver, they prevent directly the triglyceride synthesis. So if you were to eat your bad fats also with the omegas presumably prevent liver from converting the excessive fatty acids into triglycerides. So that at least is the thought. There are plenty of animal studies. Human data is not so clear, but at least we have that data. So all sounds great. Unfortunately, I'm going to show you there are 3 studies that came out in New England Journal last 2 years that unfortunately were negative. So, for example, this particular one looked after myocardial infarction. There was some prior data before from GC trial that omega-3 supplementation prevents actually sudden death related to coronary disease, and there are some others showing that actually omega-3 fatty acids are important to reduce triglycerides in patients who have hypertriglyceridemia. Okay, so the question is, does it also reduce coronary disease-related outcome in a double-blind randomized prospective study? And this alpha omega trial group, they randomized patients to 2 grams of omega-3 fatty acids, and they follow from who already had a myocardial infarction, and they found that low-dose supplementation did not significantly reduce the rate of major cardiovascular events among patients who had myocardial infarction. Another study is worth mentioning came out actually within the last 6 months, and they use 1,000 milligrams of omega-3 fatty acids, so not 2,000, 1,000, with recent myocardial infarction and heart failure, and then they look to what's their risk in developing diabetes type 2 and what happened to the diabetes-related outcomes. And unfortunately, this was negative too. They did find, though, that the triglycerides were reduced at the end of the study compared to the beginning of the study, and that was a separate paper. But that's pretty much it, and especially also in patients with diabetes. So their conclusion was daily supplementation with 1 gram of omega-3 fatty acids did not reduce the rate of cardiovascular disease events in patients high risk with cardiovascular events. So now, have I known this probably 2 years ago when we decided the study, I would have not done the study that I'm showing you. But now looking back, I'm happy I did it, and I will show you why. So I took the mice, and these mice were on the ALIOS diet that has about 40% saturated fat. So I told the nutritionist from the company, I said, I want to replace part of this saturated fat with the equivalent that would be for a human either 2 grams a day or 4 grams a day. And that will be equivalent scale down for these mice. So that actually goes to, I put here omega-3 2 grams or 4 grams, but it boils down to about 0.7% versus 1.6%. So if you think about 40% is the total. So from that, you just take about less than 1% or around 1% off, you still have 39% is all bad fat. And that was mixed in the diet. So this is important to understand why I did the study. This is not, I wake up in the morning, I take my omegas, and then I'm going to eat 3 hours later. It's actually, you do it when you take the bad food. All right? So when we did this, actually, and we did the same study for 15 weeks, not 16 weeks. Again, you look at the fraction and shortening, the control ALIOS, the ALIOS diet, again, reproducibly, it causes some cardiomyopathy. And then when you put them on 2 grams, it starts to get better. When you put them on 4 grams, it starts to get better. It doesn't go perfect back to normal, but clearly it's a dose-dependent effect, and that's very important. When we look at insulin resistance, only the high dose, actually impaired glucose tolerance is more correct, only the high dose appears to actually reverse this, and it does that only by a later on time points, 12 to 15 weeks, not as early as 4 or 8 weeks when we discovered the insulin resistance, impaired glucose tolerance. So again, the high dose, not the 2 grams, for 4 grams. And then when we look at the liver, so this is a control liver. These are veins here that, let me see, it looks nice, red meat. When you put them on ALIOS diet, you have these big fat bubbles, okay? And then we put them on 2 grams, and it starts to reduce and put them on 4 grams, it's even less. Of course, that's not very clear. I say, well, how do you know all those white spots are really fat? Then we did a special staining just for the red, it's called oil red O, which is only for the fat part. And then the changes are actually much more dramatic. This is a normal liver, shouldn't really have much. This is the one that's seeing ALIOS. You see about half of the whole liver is replaced with those fat infiltration. And when we quantify the effect of omegas, actually, you control ALIOS diet, gets you close to 40% of your fat infiltrated with, liver infiltrated with fat. And then omega-3, only 2 grams start to reduce it. It's still statistically significant, but nothing major. But once you get to 4 grams, there's a drop by about 3/4 of the original fat infiltration, 40% to 10%. So that's actually very dramatic. It's actually as dramatic as any other drug has ever used in this NASH model to improve liver steatosis or cirrhosis. So I didn't look at cirrhosis, it's just, hepatosteatosis, but it's very dramatic. So what this begs the question is, obvious the liver steatosis improved more than the heart part, okay? And the insulin resistance, and only after long exposure, not short acute exposure. What this suggests is that the main problem was the liver causes probably insulin resistance, and this is speculative at this point, then the insulin resistance causes the cardiomyopathy. Once you fix the liver, the insulin resistance goes away, then cardiomyopathy gets better. That's why the effect is delayed. And the effect is also dose dependent. It looks like the more junk food you're going to eat, the more omegas you might need. Okay, so this is very simplistic. So I will summarize this, that so far the data suggests that morbid obesity is a marker of cardiovascular disease. It's really more of a marker. Now per se can cause disease too, but what I think is more the how you acquire obesity that makes the difference, at least in the last 20 years, at least in this country and in the world. And I think that's very important take-home message. There are clear elements in the food that comes from mass industrial production that are reproducible, they're used everywhere, and they eventually make it up to us. I'll give a simple example, and I don't know, this goes on the emotional side, so please try to just extract the potential science part of it. But bottom line is, about a year ago, I had a patient who I was worried that, it had very low ejection fraction, it got better, went back to work. I said, what do you do? So it turns out his job is to go to he has the whole Southeast account for Burger King and McDonald's, takes all their used oil. Everything has been used, burned, to make the burgers and the fries, takes all that oil that's oxidized and foul-smelling, and their company takes the smell away and puts it back into the pet food, chicken feed, cow feed, everything goes into industrial stuff. And, while you may say, okay, well, we clean up everything, this has the highest FDA standards, I'm not sure what they're going to do with the oxidized part of it. Bob can think more about that. I can tell you that I bet you if somebody does a study, we'll find that all those chickens or whatever they are fed, they are diabetic. And that's what happens, and it eventually gets into us. Anyway, that's just a take-home message, a simple observation, that we have no idea what's going on there. The second thing is, all we know is that in 20 years, we have becoming fatter and sicker with diabetes than we've ever been in a million years. The second take-home message is that cardiomyopathy associated with Western-type diet is related to insulin resistance, and it's really more of a starving metabolism, while liver is the one that is actually over-binging and over-depositing, the same like adipose tissue. There is a very strong connection between liver steatosis and coronary disease, which points to the fact that nutrition is the source for both. Third, treatment with an ACE inhibitor, at least there is some evidence in humans, like the HOPE trial, but also in animals I showed you, prevents cardiomyopathy and obesity in mice fed with Western-type diet, which begs the question whether it's worth starting primary prevention ACE inhibitors, low dose in humans with obesity. And then treatment with omega-3, 2 and 4 grams, improve liver status and cardiomyopathy in mice. Unfortunately, clinical trials in humans with low dose, lower than what we have used here, have failed to show a major impact in cardiovascular outcomes in patients with diabetes or myocardial infarction. And I hope I showed that, at least in animal studies, there's clear dose-depending effect that should not be ignored. I would really like to thank Bob for his forever support since I've been here for almost 15 years. Really, a lot of the original diet and thought process actually was suggested and work as collaborative work with Dr. Frank Anania. He is the head of hepatology at here at Emory, and I'd like to thank all my fellows who actually have did this job, and I'll be happy to take any questions. Thank you.
Thanks, Dan. That was a great talk, pulled together a lot of information, very provocative. So from a clinical perspective, what am I supposed to do with omega-3 fatty acids now in my patients? You know, I've spent years getting them all on 2 or 3 grams. Should I leave them on? I think it'd be helpful. We all had some advice on where to go with that.
Well, as always, you just got to be honest with the patient. So I always tell them, well, I'll tell you what the evidence shows. I also tell you what we don't know, and also tell you what I would do if you're my dad or my mom. And so the first question is, the evidence shows that it really is not very effective, except evidence-based medicine shows only one improvement, and that is in reducing the triglycerides if you use 4 grams a day. And that's clear. What we don't know is the impact on diabetes and the impacts on heart attack or preventing mortality-related cardiovascular disease, and I will tell them that, and unfortunately recent studies have been negative, that with a dose of 1 gram or 2 grams a day. And then third, I will also say that I'm privileged to more information about this, and as long as the source is clear, and I think there are more studies going on, and if they tolerate it well and they can afford it, I would, if despite having perfect evidence, they could consider take that, but that would be my personal opinion, which I now will acknowledge that that's biased. So,
Dan, a very nice talk, and I appreciate what you were saying about the omega-3s and the ACE inhibitors and all. But I guess if I look at this, my message, and I ask if this is your message, is the thing we know is it's too much overeating, and that obesity is the problem. And as you look at population management, isn't that the message we really should give? Is that we've got to reduce our caloric intake, we've got to get more active, and I would think that that's where we should focus. It's intrigued that the population looks for a pill to take that they can counter all this,
right?
And that's the wrong message, I think.
Right. Well, I completely agree with you. I mean, that's my most emphasis, the most important emphasis when I personally talk to the patient. That's what I teach with everybody. The whole purpose of this was, well, on top of that, look, if we fail, and unfortunately we have shown too many times we failed in really how many patients really lose more than 10 pounds. And turns out in order to make an impact on cardiovascular disease, you need to lose at least, although everything matters, even 5 pounds, if you keep it constant, you really need to use about 20% of what had happened there once you are morbid obese. And very, very few, unfortunately, are there. Not that I completely agree, we should make every effort to get there. But while we're waiting for that, we should also find ways of how, it's not just the patients, the whole social infrastructure, it's the industry, it's the humanity part of it, is the addiction has been increasing for you. We are a going out society. I do that every day. So
marketing to kids. I mean, there's a lot of things out there that we
need
to address with this.
Yeah, so within that context, if we can prove that something like omega-3, that you can mix it up with your bad stuff, doesn't alter the taste. Maybe we can tell, well, you need to have a ratio of 1 to 6. If we prove that makes a difference, then maybe there will be one way of trying to get the industry buying into that. But this is just more of a, thought.
So another component of industrialized diets is the amount of salt, and I was wondering if the ALIOS diet is different in the amount of salt to the control, and what do you think how would that high salt diet interplace with a high caloric diet?
So those mice have an equivalent of a human somewhere between 5 and 10 grams, depending how much you eat. So to me, that's actually a typical American intake. But if you were to ask the Italians, they only have 3 grams of salt. If you were to ask Yanomami Indians, they only have 20 milligrams sodium a day. 20 milligrams. This has been studied. It's been it's been published over 30 years ago. All right. And if you were to ask a Japanese from Akita County, where is the highest incidence of salt intake, they eat 40 grams of salt a day. So anyway, but these particular mice reproduce what we are supposed to eat, 5 to 10 grams, which is still a lot, because the most recent recommendations from FDA is to drop that to 2.2 grams a day if you don't have any condition less than 1.5.
Thank you, Dan, for a nice talk. I'm curious to know if you looked at the lipid profile of these animals that you had put on this diet. Do you know?
I personally haven't looked, but the Tetrick group, who has published this in 2008, gave a very detailed analysis. So triglycerides go up. Mice don't have a lot of LDL; they have HDL, but their HDL goes down and the LDL goes up. Pretty much reproduces every. Uric acid goes up, and I don't know if these guys will ever get gout attacks, but seems to. And eventually they get high blood pressure too, at least in high fructose, specific diets. So there's a lot that they actually reproduce metabolic wise.
Thank you for I think the ACE inhibitor findings were interesting. My question is, was the effect probably, do you think it was a central effect? Maybe those mice were not eating as much, or was it purely, did you have a food diary? Were they eating the same amount? Did it actually inhibit their appetite?
So it's this has been studied by other groups in different animal models. And I can tell you these mice definitely eat less. If you do a calorie count, actually they have much, much less intake than food. So clearly some direct central effect of the ACE inhibitor. So it's hard to sort all that out, all that into this. This is actually one of the criticism, but at the same time also begs the question is clear in our developing the addiction for this kind of food or the insulin resistance in the brain, there is some role for angiotensin activation there in the brain. But yes, they have that.
Has anyone given these mice metformin on this diet, and what did that do?
Not on this, not on this diet. That would have been my next study. But in humans, we have evidence if you give metformin, high BMI, metformin, or losing weight, you prevent diabetes. Actually, metformin is very, very, probably the most beneficial drug we have right now in preventing cardiovascular outcomes in patients with type 2 diabetes, not insulin. I'm talking about type 2 diabetes. Okay.
It's an advertisement actually for noon conference. I'm going to present that.
Yeah, all right.
Okay, well, thanks so much, Dan. That was a great talk. Really appreciate it.
The preceding program is copyrighted by Emory University.